Okay, welcome listeners. Thanks for joining us again for another episode of the eGPlearning Podblast. I'm Andy.
And I'm Gandhi.
And we're here today doing an interview episode where we have the honour of being joined by Liz from ORCHA Health.
Hi Liz.
Hello, thank you for having me.
That's fantastic. So we're going to be talking a little bit about ORCHA, which is Liz's company and Liz's sort of enterprise and baby, and how it's helping people understand the emerging area of health apps and helping people navigate that area. We'll be covering some interesting developments like ORCHA's involvement with the NHS app and NHS choices, and probably going off in all sorts of different directions because we're going to have a nice conversation with Liz. So I guess to kick off, Liz, do you want to just introduce yourself briefly to the listeners?
Yes, of course. So my full name is Liz Ashall-Payne, and I am Chief Exec and Co-founder of ORCHA. ORCHA stands for the Organisation for the Review of Care and Health Applications. Now, I didn't always work in digital health. I started out my career as a speech and language therapist who created, I had an expertise in complex paediatric care.
Okay.
And my background is the NHS, and not just from a clinical perspective, but also from a systems perspective. So I got really interested in how we can do things differently to benefit health outcomes, and that's why I got interested in digital.
Oh, fantastic. Liz, so many of the viewers out there listeners may have already experienced ORCHA, but for those who haven't, just explain what is ORCHA? What is it?
Yeah, of course. So I think if people know about ORCHA, people might know us because they know that we review healthcare apps, and we do, and that's an absolute core foundation of what we do. However, our mission isn't to review apps. Our mission is to distribute great apps and activate people, patients and professionals to be able to search, find and embed good solutions into their work life and practice.
Fantastic. So I'm just trying to absorb that. So for people out there who haven't got any knowledge of ORCHA, how would they find ORCHA, and what might be some of the first things that might be useful to them about ORCHA?
Yeah, no, of course. So I'm going to go back to why, if it's okay, I'm going to go back to why ORCHA was created. So the 327,000 healthcare apps available to us, huge amounts, and this is growing all the time. Every day 5 million people download a healthcare app. Wow. And over 90% of clinicians think apps could help their patients if they knew which one to use. And so there are 4 big problems and the reasons why we haven't achieved uptake, and I'm really interested in whether you agree with this or what your colleagues feel.
Okay.
The first is awareness. People aren't aware that these apps exist. You know, if I think back to my clinical training, which was 20 years ago now, the degree is actually quite similar now to what it was 20 years ago, and actually the world's moved. So awareness isn't great. Then we've got a problem of access. Once we know that these apps exist, where do we go to find good ones? The app stores don't work. The third problem is trust, real challenge. That's the ultimate problem. And then the fourth is governance and management of risk. And so when you come to ORCHA, what we've done is we have supported all of those 4 problems. So we review apps in a very rigorous way, which I'm happy to talk a little bit more about. But you can very simply go to the ORCHA app library, search and find apps, and know whether you can trust them because we've done the rigor for you. And there's a whole load of information about clinical assurance, data security, information governance, user design, etc. And so what that means is that we're supporting the whole community who's interested in health apps to be able to find apps very quickly in the way that we can find holidays.
Excellent. Liz, what I really love about your approach to ORCHA is that you've approached it from a problem to solve. You know, you've not come with a solution, and I really love that about ORCHA and how it presents itself, and about how you articulate the problem as well. Can you tell us a little bit more about the rigour? Because I think for our listeners, a lot of them are medical professionals, and when we're prescribing drugs and actually other psychological or behavioural-based treatments, we're normally aware, or at least aware, that the regulators or those people who produce the guidelines, are really seeing some rigorous research into whether or not they're going to work, whether or not it's worth the patient's time, what the risks are. But when we're thinking about recommending an app or something like that, we don't have that knowledge, and that makes us quite unconfident potentially about recommending things. So that's something I really respect about ORCHA. So can you tell us about your approach? You can dive in quite deep if you like. So what do you do that enables us to trust the apps that ORCHA recommends?
Yes, okay. So just to give you some context, we've reviewed just over 4,000 health apps. And the thing that we do is we don't just review apps once. Apps change all the time. And we know when the app has changed and we re-review it. Now, in some instances, so earlier on in the conversation, prior to us doing this, we were talking about Headspace. Now, Headspace changed 6 times in the last 4 weeks. So you need to know as a professional, not just was it safe, but is it safe? Yeah. So I'm going to start that review process from the beginning, because that's a fundamental point. So what we have is we have a weekly data scrape, and that pulls in all the apps from iOS and Android on a global scale, and it pulls all the data in from health and fitness apps. And the first thing we do is we get rid of any redundant apps. Now, apps that are redundant are apps that haven't been updated technically in the last 18 months. If an app hasn't been updated technically, it will have data security potential breaches, but it's also a proxy to say if nobody's looking after it technically, it's highly likely nobody's looking after it clinically. So we get rid of those. Now, what's really scary is 2/3 of that 327,000 apps are disqualified at that point.
Mm-hmm. Right.
So there's a lot of apps, but not a lot of great apps.
That's probably true.
Get rid of those 2/3 of apps. Now, we do contact the developer to tell them, because if they want to update it, then next week they'll come through that filter. Then what we do is we curate the apps into 260 clinical condition areas, and we rank them in highest downloaded app backwards. And what that does is that gives us a cue to make a decision about which app to review next, because if people are using apps, they need to know if they're safe. Now, just as an example, that's really helpful. And if any of your listeners want to know more information about that, then get in touch. So I had a hospice on the phone the other day asking how many palliative care apps are there. They'd only been able to find 3. Well, there were 767. So finding a list is hard.
Wow.
Just even find that long list. Now, that's before we even start the review process. Then what we do is we pick the next app, and we first of all classify the app, and this is really important. So for any apps that you're looking at as a clinician, not all apps are the same, and not all apps hold the same amount of risk. So we have a classification system, and what we do is we work out how complicated the app is, and therefore what the risk is. So if you think about the way in which drugs are classified, that's what we're looking at with apps. So is it a very simple app like Brush DJ, plays music for 3 minutes, but highly effective for children in brushing their teeth for that length of time? Or at the opposite end of the spectrum, a level 4 classification app, is it a medical device that's built on clinical algorithms that may interoperate with clinical data sets? Completely different products. So an example there might be the Mersey Burns app, or Neomate, or Skin Vision, completely different products. So we classify the app first, and then we work out what does the app do. So some apps are like a book, they give you education information. Some apps have gamification in them. Some apps have the ability to create a care plan. Some apps social networks. And depending on the function, that depends on how we review the app.
Wow, yeah. It's making sense.
Definitely.
And very systematic.
Yeah, well, we have to be independent and objective, and also try and make sense. It's really confusing. You wouldn't assess transport across the breadth in the same way if you were looking at the safety of a bike compared to a rocket, and that's what we've got with apps.
Okay.
So Liz, just had a question pop into my mind, and I might forget if I don't ask it now. You obviously see lots and lots of apps, and I was just wondering if there were any common mistakes or problems that crop up again and again that you'd like to point out. There may be app developers listening at the moment. Any tips or comments?
Absolutely. And the first thing to say is it's really confusing landscape. So there are 2,500 standards, regulations and best practice that you might need to consider for your app. Now, if you're an app developer, more often than not, you don't have a huge team behind you. So just finding out what the standards are, then applying them is a challenge. But the kind of common omissions that we see is very much pertinent to the group of people that have developed the app. So let me give you an example. We're all clinicians. If we developed an app in our clinical expert area, we're probably going to make it quite clinically sound. We're going to probably know how to make sure that we've done the right clinical trials. We're going to probably know how to and where to publish data, how to make sure we know whether there's been an impact on patients' health outcomes. But we wouldn't necessarily know about all data security requirements, because that's not what we're trained in. So what we see is the gaps emerge as a consequence of the knowledge base of the developers.
Okay, so do you see some of the better apps coming from more blended and mixed teams? Is that what happens?
Yes, absolutely. Yeah. So I mean, and one of the things that I always say is I am yet to find any single person that knows about every single standard in any level in a significant amount of detail. And so going back to our review process, once we have worked out what the classification is and the functions and features, that then works out using our accreditation engine which questions need to be applied to that product. And as we're going through the questions, what we have are app review coordinators who hold the ring in gathering evidence and then hand that information off to subject matter experts in the different domain areas. So our clinical safety officers wouldn't be the right people to ask the data security or the information governance questions of. And so we ask the people who've got the expertise, and then they feed their information back into that central point. And at the end of that process, the app receives a score, and that score is out of 100. And so there's a percentage score. People quite often say to us, well, why don't you just say approved or not? And my response to that is, I think we need to mirror in digital health what we do in drugs. Now, when you buy a packet of drugs or you get a prescription, you get that packet. Inside that packet is listed all the side effects. And that's what we want to do with digital health. There is no perfect drug out there. There is no perfect digital health solution. And if we can at least inform people of what those risks are, and the risk might be it doesn't work for people with a visual impairment, but you've not got a visual impairment, you can use it. But if you have, you might want to find yourself a different product.
Okay. So, I mean, definitely in terms of that process, it's definitely I would agree with. So Andy knows this, but you may not. A while back, I actually created an app for clinical use. So it was a teledermatology app. It was called Photo Consent. The reason you won't find it now is because of one of the reasons you mentioned earlier. It was about the updating side of things, because I wasn't able to keep updating it myself because I didn't have the skills to keep going back and doing that. And then actually there was an issue with Facebook bought out the back engine and closed it, so therefore to change that would have been quite a significant cost, so therefore, to be honest, didn't upkeep it. But I can definitely hear why that process is really important. I guess one question I had, which is in a sense similar to this kind of vein though, as you mentioned, doctors, clinicians, that kind of stuff will look at drugs and try and evaluate how we use those to manage patient conditions and that kind of stuff. And ORCHA really does what I can see a great job in terms of doing a similar application to health apps and stuff. One of the questions I often get from clinicians though is, where's the evidence to show that a health app will actually be beneficial for the patient outcome over something else? So have you got any, I guess, pointers on that and stuff?
Yes, I mean, It's a really, really interesting point, and I think there's a lot of work to be done in this space. So at the moment, obviously what we're looking at is the impact evidence for the health app, and that feeds into our review process. But what we are seeing at the moment is almost a competition between digital and drugs. So you see some digital health products say we achieved a 5% improvement on what you saw with drugs. And I think that's the wrong thing to think about. What we need to think about, yes, we know what the impact is with drugs. We know what the impact is with digital health. What's the impact when we bring the two things together? And for whom does which approach make most sense? So mental health is a really good example. Children and young people, we don't want to be prescribing loads of drugs to that community. No. So let's have a look at what digital health impact has for that population. Now, in the adult community, where we're prescribing drugs and potentially prescribing apps, where do we see the biggest impact for either one or the other or both? And that for me is where research needs to be moving.
Do you think does ORCHA, because you're capturing quite a lot of the activity in this space now? Is there a future role for ORCHA in augmenting the collection of impact data in some way? I'm just wondering if you have any plans to the future to solve that problem too.
So we don't hold any patient data at all, and we're not interested in the patient data. Well, obviously we're interested in it, but we as a company, we're not interested in it. So what we do is we have loads of information about the health apps. You have, as a clinician, have loads of information about the patient, and we want you to use the information about the patient to be able to search for, find and filter for the best app for that patient. Now, what we then have is our system then allows you as a clinician to prescribe or recommend an app through the system using a text message service, so that the patient receives an app on their phone. Then what we have is when the person's downloaded the app and we know whether they've downloaded it or not, that's where our data shuts. However, our plan and at the moment, one of the things we're doing with a number of app developers is we're inviting them to share usage data and stickiness data of the apps that they have had prescribed to them. Plus, what we have for everybody that has a recommended app is a leave a review. And this is written like a patient-reported outcome measure. Now, we're crowdsourcing that information, so thousands of professionals use our system to prescribe apps, and we can crowdsource that patient-reported outcome measure across a whole range of different demographics. And we want to use that information to further refine our app matching, so that in the same way that we're moving towards precision medicine, we need precision digital health, and that's where we want to go.
Cool. So I guess a question I would have then on that point, at the moment, if I wanted to prescribe a drug, obviously go down a particular class or something like that once I've decided that's probably the best treatment for the patient and things. And if there was some confusion, I'd probably refer to some text, so obviously guidelines, or potentially the BNF, so the British National Formula and things. So if, as a clinician, one of my colleagues wanted to go out and do the same with apps, how would that journey be for the clinician in terms of getting that information to the patient? So effectively, do you have an equivalent of the BNF, and how would they use it?
Yeah, so we have multiple BNF versions. Okay. So we have the ORCHA App Library repository, and from that we work locally with either CCGs, local authorities, providers, GPs, to create locally targeted and locally branded app libraries that are promoted to the professional community. Now, that is your local BNF, if you will, for digital health. You can then go there and search for and find apps. It's not just about saying, I want the diabetes apps, which you'll get hundreds and hundreds of apps that we've reviewed. You then filter to find apps for a specific demographic, so you can filter according to age. So if you've got a child with type 1 diabetes, you're not going to want the same product as an adult, etc. Then cost plays a big role. We need to know what the cost is. Then functions and features. If I'm newly diagnosed diabetic, I want information and education. And then you hit search. And what you'll find is that very long list goes down to maybe 2 or 3.
Okay.
And You can click on the app and it gives you lots more information about the background review to that product. There's then a little button that says recommend this app. Hit recommend, type in the patient's email address or telephone number, and within 2 to 5 seconds the patient will receive the app on their phone. And one GP who uses the system said, you'd never wave a packet of drugs at a patient and say, go and buy these drugs. And unfortunately, that's what's happening at the minute with apps. We go in, use this app. But the problem is we then have no way of tracking what happened. Using our system, the patient's going to get the app that you're recommending. We can then tell you then get a dashboard that says what apps you've recommended to whom and when they've loaded it.
Oh, that's very interesting.
So I have to admit that sounds really attractive, because as a person that recommends apps pretty much almost every day, I have to admit I didn't even know that existed. So that sounds really attractive to me. And I guess we're going to see the big advent of apps coming in the next few months. Obviously, the big game changer is the NHS app itself that's coming to the full market in the next couple of months. I mean, we're a pilot practice for the uptake of it at the moment.
Right.
And I know that the plan is, I think it's June or July that it goes for full release and stuff. So how do you see that changing it from your perspective, obviously, as ORCHA, and particularly in terms of patient engagement?
So I think the first thing for me, behind digital health, our government have really got its policies and strategies aligned to taking this forward. Contracts, incentives, everything is aligned, which is brilliant. And what that does is that drives trust. It drives trust is the ultimate challenge in this, and it's not just from a clinical perspective, it's also from a patient perspective. Facebook and Cambridge Analytica did us no favours in trust, and quite so. Having an NHS app, having the NHS behind digital health, makes people think, I can use this. Plus, if you as a GP or any clinician or trusted professional is recommending a solution, it's the trust again. That trust is so important. So we see on the back of the recommendations, 71% download an app when it's recommended to them. 71% of people. Drugs, the data for people picking up drugs post-prescription is only 74%.
Yeah.
And this is innovation. People are ready, but they don't know which. So I think the NHS app will help build trust. I think the second thing is, within the NHS app, there is also a plan to embed other digital health solutions into that product. So obviously the NHS app is particularly going to be focused on booking appointments, repeat prescriptions, etc. But actually, once you've got the person into that environment, there's a whole range of different products and solutions that they could benefit from. And because it's in the NHS app, they're going to trust it.
Yeah, fantastic.
Which I know with our previous episode that we did about it, so we did one talking about the NHS app itself and how the creation of that was happening, how effectively it looks like it's going to be the front door for the digital engagement of healthcare for the UK moving forward for the next however many years and that kind of stuff.
I particularly liked how they, it sounds like they're trying to position it as a platform on which to build and link in other apps, potentially allowing them to share data in a way controlled by the user with one another and with the user and with the health record, which I think is really, really exciting. Because you not only know that they've downloaded an app, but potentially that they are using it, how they're using it, how is it affecting their health, which is really, really exciting.
It is, and I think that so we're doing quite a lot of work and with a whole range of different stakeholders in this area, trying to support that data sharing from apps and personal health record into a clinical data set. And you picked up on something there that's really interesting. So it's up to the patient. The patient will be able to choose who gets to share, who gets to see that data, and that is really exciting because that's very new, but I think that's the only way we can scale it.
It is, and what excites me about that is because the patient's in control, people have different attitudes towards sharing their information, and when you're in the control of somebody else's data, you have appropriately a very cautious attitude towards sharing data. When patients are in control of their own data, I think we might see actually more data sharing because they can choose exactly what they share. and it's easier to be relaxed about your own data rather than somebody else's. So I think that's potentially going to provide some interesting developments.
I mean, I completely agree. I'm type 1 diabetic, and I would love to be able to share my blood sugar readings with my GP too, because to be honest, I'm never at home. So I don't have time to go to the doctor, and really they don't have time to see me. I'm well controlled. I'm an appointment that they probably don't need to have. Mm-hmm. If I could just share my regular blood sugars with them, then they can know that I'm not somebody they need to worry about, and actually let's invest our resource and energy over here in the patients who really need it.
Mm-hmm. Yeah, absolutely. I've just been listening to how you talk about the review process and how ORCHA operates, and we have different entrepreneurs that we talk to, and some are from large organisations, some are from small organisations. The way you describe the process, it sounds like it's enormous with lots of people involved. I mean, is it?
So it's a really good question. We have spent years and years building that process, and it is built, I mean, I describe it as an engine. It is built like an engine. So it started out life as a spreadsheet, as you can imagine, with loads and loads of macros and highly complicated, and then we've built it as an engine, and that's how we're able to review 400 to 500 new apps every month and re-review every app, over 4,000 on the libraries.
Wow.
We always started this vision with we needed to scale. This is a global problem. But we also wanted to get it right in the NHS, because that's what runs through us. Our value base is so aligned to the NHS. So are we a huge company? No. We have, and I say about because we're rapidly growing at the minute. So we have a workforce of around 20. We've got about another 7 or 8 jobs that we're trying to recruit to at the moment, and that will continue to grow. But a lot of our focus obviously is on the review process. But we also have a team that's all about implementation and supporting people to be able to use the product once they receive it. We have a whole team around research. So we have a head of research, and we invest a lot of resources into research in this area. So we're doing a really interesting piece of research around trust at the moment. What would make people, professionals and systems trust apps? If anybody wants to be part of that piece of research, we're going to have the survey launched.
Yes. Well, we've got people listening, obviously, so we have to put a shout out. You shout out now if you've got any particular email address or anything.
Yeah, okay. So get in touch at hello@orcha.co.uk. We'll be launching that survey on the 4th of April at the Royal Society of Medicine Mainstreaming Apps Conference, where we're speaking and sponsoring. So anybody who's going to that conference, we will be asking you to complete it. But it's an online survey, and we're so keen to know what would help people feel comfortable to trust digital health.
Great. Liz, you clearly come from a speech and language therapy background, and you sound like a clinician. When we're talking to you, you can hear that coming through. But you've also clearly got lots of business skill, technical skill. Can you tell us a little bit about your story and how you came to have all of these really valuable skills?
So I think the first thing to say is I like to learn, thankfully, because I have had to learn a lot very, very quickly. So I'll tell my story. So my passion and the reason for me wanting to become a clinician was because I always wanted to help people. Now that's a very, very basic thing, but that's what I still want to do. That is still why I do what I do. So I wanted to help people. So I trained as a speech and language therapist, and I was absolutely delighted when I got a job, and I was initially a community therapist. So I went into my clinic on day one and started seeing patients. And at the end of that day, I thought, this isn't going to work. I've only been able to see 6 patients. That's not good. And when I turned around and looked in the corner where there was a big filing cabinet that was filled with patient notes, I thought, what about all those people? And obviously we didn't have electronic health records then. It was a filing cabinet. And I thought, well, what about all those people? And what about all the people that are waiting to be assessed? And what about all the people out there in our communities? and I thought, so that took me on a journey of wanting to drive efficiency. So I got really interested in lean methodology, quality improvement, changing, sorting out the pathway, being as efficient as possible. So at the time I lobbied for us to have computers on our desk and printers so we weren't having to photocopy letters. Yeah. So I was trying to drive efficiency. And I did, and we absolutely did what we could as a team. But it still wasn't enough. There was still so many patients. And I thought, doing what we do just faster isn't going to be enough. I need to do things differently. And this was before the smartphone had even been invented. So I got really interested in system transformation. So how does the wider system enable you as a clinician and a healthcare professional to be able to deliver care differently? So looking at financial incentives, culture, workforce development, leadership, etc., all these different elements. And I worked with the King's Fund across the Northwest, working with system leaders to learn about, well, what are the incentives at that system tier? And that was amazing. And then I actually went off to have a baby. So when I was on maternity leave, I saw a job advertised for a digital health lead at an academic health science network, and I thought, don't really know anything about digital health, other than I have a phone myself, and I know that this could be a way in which we could support more people because we all have bought these things called smartphones. So and I also knew about change management, and I knew what needed to be done to embed a new product or service or process. So I went for the job and I got it, which I thought was very innovative of the AHSN to put me in. And what that did was that then opened my eyes to the amount of solutions that were out there in the world. And my job then was about trying to find good solutions and embed them into the NHS so that we could all benefit from them. And I couldn't do it. And the reason I couldn't do it was because of those big barriers. People weren't aware, they didn't know where to go to pick them up, but they didn't trust them. And I thought we need a different approach. So I did what I could, and then I took a job working across Europe, then with an organisation called the European Connected Health Alliance. And that job was very similar to an HSN, but I was now helping systems across the whole of Europe to think about how they embed digital health to benefit patients' health outcomes. And I thought, this is crazy. I can't run around trying to talk to everybody in the world about certain products. And so that got me absolutely obsessed with the opportunity and my frustration that we weren't necessarily able to benefit from that opportunity. And I thought there's got to be a systematic way that we can do something different here. Now, I never planned on setting up a company, ever. I was very happy doing the work that I was doing. But I talked to anybody who would listen to me because it's a problem that I was facing every day. And I happened one day to talk to somebody who knew some investors I didn't know, and I was just talking to this chap about the problems with health apps, and he said, have you got a business plan? And I said, no, because I've not thought about this as a business. And he said, well, go and write one and I'll put it in front of some investors. So I thought, okay. So I went home, said to my husband, I've had this really weird conversation. And his background is business, so we wrote this business plan for what, and we called it ORCHA, and I sent it to him. And now it gets really surreal. So 3 weeks later, I get a telephone call, and it's Sir Terry Leahy, the ex-chief exec of Tesco's. And wow. He said, I've received your business case, your business plan. Wow. I'd like to have a few questions with you about potentially investing in this idea you've got. So we had what I describe as the Dragon's Den conversation. And at that time, I remember vividly thinking, I'm just a speech therapist. I don't know any of these answers about profit and revenue and valuation. Anyway, he obviously liked the idea, and I got an email very soon after to say, yeah, we'll back this, we'll invest in it. So that was the start of ORCHA. Now, since then, I have had to learn very, very quickly about how to structure a business, run a business, grow a business, And I think that my saving grace is I really do know what I'm not good at. And so thankfully, because of that, I've gone, I don't know anything about this area, I need somebody to help me with that. So for example, my co-founder, who came on very, very quickly, his background is a lawyer, and he's also worked in private sector as a commercial director. Perfect. I don't have those skills, I've not got that experience, I've not got the expertise. Brilliant. I need you to help me. So that's my story.
Wow, interesting. It's you know what's interesting. I thought you might say, "Oh, I tried this first and it didn't work, and I tried that," but it sounds like you were just there's a problem, ORCHA, bang, and it's exploded, which is fantastic.
So I've got a question. Why ORCHA?
So I knew that I wanted the company to be an abbreviation. Yeah. Maybe that's because I'm from the NHS. And we love abbreviations in the NHS. But I knew I wanted it to be an abbreviation, but I wanted the abbreviation to also be a word. And genuinely, this is what happened. Me and my husband sat on the sofa and wrote down words that felt right, and then tried to create an abbreviation that meant something. And we had we've still got it. We've still got the list of all the different options, but ORCHA really stood out. And then we started thinking, obviously it's ORCHA with a H for health. And then we started thinking, well, ORCHA's obviously a whale, a killer whale. Is that really a good idea? And actually, we started researching. Well, what do orcas do? And one of the great things about orcas is they work together in pods and they work together as a team. And they are very, very collaborative. They're very family orientated. And I thought, do you know what? I know they've got the word killer in them, but actually, as a unit, they work together. And one of orcas' big values and elements of the whole team is we're collaborative. We love working with other people. So it just felt right.
Oh, great. Oh, Liz, something that was really interesting when we were talking pre-interview was we were talking about the responsibilities for health, and you had some interesting things to say about that. Do you want to replay a little bit of that conversation, because that was fascinating?
Yeah, so I think, health is not just the responsibility of ours as clinicians or as the NHS. Health is everybody's responsibility, and I think we are seeing that emerge more and more over time. Now, the responsibility doesn't just sit in the NHS, it also sits in local authorities, it also sits in education, police. We see on the news one of the reasons for a lot of crime is down to mental health, so it's everybody's responsibility. So how do we work cross-sector to get the most benefit? And we asked this question ourselves. So we said, everybody's bought phones. Who uses phones the most? It's the digital natives. My son, for example, he's 13. He can't imagine life without his phone. He has an actual relationship with his phone. It's like the digital natives. So we said, well, I wonder whether let's just pause and think about children. Where do children go? They go to school every day. And they use the phone, and they love using their phone. Now, the interesting thing about health and children is children spread disease and infection. So we said, well, I wonder, and this was actually on the back of a conversation with Tony Young, who is NHS England leader. Are you okay, Andy?
Yeah, I'm fine. Carry on.
And,
sorry.
And he triggered this thought. So if children spread disease and virus, could they spread digital health? They're in schools. They're not going into GP surgeries. So how do we target them? Well, an obvious thing in a secondary school environment is PHSE. That's when they're learning about health and social. Teachers don't know what to teach. So we said, well, let's give them some lesson plans. Let's give them access to this resource we've built, a health app library. And so now teachers can come to us. We provide lesson plans, resources, videos, workbooks. The young people are taught about health, mental health, digital health. They then go to a portal that's now called Digital Healthy Schools, which is linked to their school site. They can search and find apps, and then the viral part is the children then use the ability to prescribe apps. They use the text messaging to text apps to mum, dad, grandma, granddad. They know if they smoke, they know if they're obese, they know if they're diabetic, they know if they've got COPD. So they then distribute these apps. They then go home and say, did you get that text message I sent you? And mum might say, yeah, but I wasn't sure. I'm not sure I can trust it. Well, you can, because I've learned today that it's gone through a rigorous process. Oh, and by the way, I can show you how to use it. It has been phenomenal. That programme, we're now in more than 400 schools, and I'm desperate for every school to have it because kids love it. Parents love it. The impact is massive, not just on the young people, but also their parents and grandparents. Yeah. It's transformational.
How if somebody sat there and their spouse or partner is a teacher or involved in education, how would they find out more about that programme?
So they can go to www.digitalhealthyschools.co.uk. And you can literally sign up there to download the resources. Obviously, if you want to talk to us, then get in touch at hello@orcha.co.uk and we'll talk to you. What we're seeing at the moment is people are commissioning this programme for their local schools. So North West London CCG has stepped into that cross-sector working and said, well, how do we work with education? This is a programme. So they've commissioned that programme for the whole of North West London schools. The same in Lancashire and South Cumbria. The councils have said, we need to invest in this from a health point of view. So they've invested in it for all their schools. But if you're a teacher, you can just get in touch and we can have a conversation on a school by school or area by area basis.
And I guess potentially for our listeners, obviously one of the other big changes that's coming out in the next couple of months is the creation of what we call PCNs, so the primary care networks. I can imagine a lot of those kind of clinical directors that are listening to this maybe thinking, how am I going to try and drive that community care aspect of it? And actually I can see this being something that within your own network you can focus on, because you can focus more on those particular challenges within your own locality. That is, if it is, for example, mental health that's a bigger issue in your schools because of deprivation, that kind of stuff, or is it other aspects of health? Are you in a pocket of population where COPD is a massive issue? For example, that kind of thing. Tackling the children to then help the adults. I guess the real benefit for primary care, we always talk about how we're just swamped at the moment with demand, and we actually know that with better self-care, patients could probably manage themselves better, and then that frees up obviously resources for all the other areas. And I think there's a general recognition that education is the way forward to tackling that, because we potentially have had this period of time where the message has always been go see your doctor for everything, and unfortunately the problem with that, the needle swung so far to the left now that we're seeing a lot of people go see the doctor for literally everything, and then they can't see their doctor because there's no space. So that really excites me actually as a potential avenue for newer organisations and stuff that are going to be coming into play in the next few months, possibly having an additional tool to tackle the community aspect, not just the health aspect, which I think many of them probably are focusing on, but not necessarily the other part.
So one of the things I was going to say is that we have worked a lot in primary care practice, but we also work with the wider communities, as you say, schools, but we work with pharmacists. So I mentioned earlier that I'm diabetic. I know my pharmacist really well because I'm always picking up insulin and blood sugar strips. So I know him really, really well. Now, he would be able to, using our, and he is able to do this because he's in an area who have the ability to prescribe apps. He can now prescribe me an app when I go and pick up my drugs. We've also integrated it into health checks, which are now being done in supermarkets. So rather than somebody receiving a sheet about smoking, they now receive a great smoking cessation app. So I think that thinking about activating communities in a different way, using the skills that are available to us and thinking about that asset-based model is really important.
Wow. There was another thing in the warm-up chat. Another thing that was really interesting to me was your involvement in the NHS clinical entrepreneurs program, and I was just wanting to hear what you're up to in that area.
Yeah, of course. So I heard about the Clinical Entrepreneur Programme very early on, and I thought, wow, that is amazing. I wish that I had been able to be part of something like that. So when I first founded ORCHA, as I said, I didn't have very many skills in this area, and I didn't know who to ask. So when I saw that programme, I thought, if I can help anybody, I'm sure that I can just give. It's not even about giving advice, just share my lessons learned, in the hope that somebody doesn't have to go down those pitfalls, because some of them were really stressful. So what I started to do was to say, how can I get involved? And ultimately what we do now as a company is we sponsor that programme, and we sponsor it by supporting that programme with mentorship and coaching for the clinical entrepreneurs. And they're all the clinicians are at different stages on their journey. And so what's brilliant about that is they can learn from each other. And we provide, we do provide advice because we have some excellent experts in the team. But it's also about mentoring and providing confidence to keep going, because it's hard. And I would absolutely say to any clinician who even just knows that there's a problem out there that they want to fix, go and have a look at the Clinical Entrepreneur Programme. It's actually open right now for applicants. It is the most amazing programme.
So we'll link to that in the show notes, I guess.
Definitely. And we've actually had a couple of people on the podcast before who've talked about it. So you may know Aisha Malik from Business for Doctors and stuff. Nick Harvey, we've been speaking on and off to, from Digitalis. And I believe there's also Chris Whittle from Q Doctors, if I remember rightly. Yeah. So hi guys, just mention you guys as well. But definitely these are people that have come as a product of that entrepreneurship program and spoke so highly of it. I know particularly Aisha. So we've actually had her on the podcast. The other two are hopefully planned. And she was actually talking about her journey, about how she got onto the program. She was literally about to start it before we filmed, before we recorded that podcast and stuff. So yeah, definitely a valuable thing and keen. I guess one of the reasons we were quite keen to speak to you as well, knowing that you were involved in that program, was to try and show the others that actually this is a route on how you could take, kind of your idea that you may have. And I guess that probably be our next question. If someone had an idea, like you did those, a few years ago with wanting to create ORCHA, what would you say is your tips in terms of how do I make an idea reality?
So I think that, Andy, you mentioned this earlier on, you've got to be obsessed with the problem. Don't be obsessed with the solution. And the reason why is because your solution is going to change. And it will change because the world keeps changing. So be really, really obsessed with that problem. And when I say obsessed, I mean talk about it to everybody and anybody that you can, and validate that that is a problem, not just for you, but for your colleagues, for patients, for the system, for the wider communities, and really understand why those pain points are there. Then when you start to think about a solution, you know which of those pain points are the most important for you to target, because when you build a product, it won't be the finished article. It's going to be, you call it an MVP, a minimum viable product. So when you build a minimum viable product, make sure that MVP is targeting the biggest problem and is therefore going to have the biggest impact. At that point, you test it and test it and test it and test it, and be really open to feedback. So one of the things I say to people is, I love hearing, it's really, really nice to hear that people like what we're doing. And I'm always saying, tell me what we're not doing right. Tell me what else you need. I want to know what the gap is, because that's the only way we're going to grow and be able to respond to ever-changing needs. So keep talking to people and asking, and people are so generous. If you ask a clinician, can you just help me? I'm really wanting to solve this problem. Can you help me know whether this is going to work? They will tell you, because they know what the problem is and they want to solve it too. That's my top tip. The second top tip is find great people. You can't do everything. So I've had a number of clinical entrepreneurs say, do you think I need to go and do a degree in coding? And the answer is no. The answer is not. Equally, if you're a coder, don't think about going to medical school. Find a good doctor, find a good coder, and work together to get the benefits from each other. So those are my 2 top tips.
Such great advice.
Yeah.
So when we have guests on the podcast, there are a few questions we like to ask everybody because we think we get some interesting answers. So the first question is, 2 parts. So what is your favourite app at work? And also what's your favourite app at play or away from work?
Okay. So I'm going to answer this in 2 parts. So I'm going to tell you what my answers are, but the answers I'm going to give you are nothing to do with health apps, and then I'm going to answer why. So my favourite app at work is Twitter.
Okay,
and the reason why is because I have got a very low attention span, and I like to consume a lot of information, and I love to learn. And so Twitter is fresh, it's there, it's happening now. I love that. It's a brilliant tool for engaging people and learning. So that's my favourite one in a work environment. In a home environment, probably one of my favourite apps is WhatsApp. And the reason why is because I have a lot of family chats, and some of my family doesn't live nearby. And parents in the 70s can use right down to my children, and we share photographs and videos, and it's a really good way of us connecting, whilst knowing the reality of us not necessarily being able to see each other as often as we'd like.
Ooh, lovely. And the underlying answer. What was it?
The underlying answer on health apps. So probably the question that I get asked most often, particularly from clinicians, is, Liz, what is the best health app for diabetes, COPD, mental health? And my answer, particularly if I'm talking to clinicians, is, well, what's the best drug? And the answer to both is it depends. It depends on the patient that's presenting. And so I think there's a myth at the minute that there is a best app for certain condition areas, and there isn't. I'm going to give you an example. If you take something like anxiety, which most people, in fact I'd say everybody has experienced anxiety, and you have presenting 3 patients, one who's a child, one an adult, and one an elderly person. Just that alone would make you think we're going to want different apps here. Then you introduce the fact that one's got an iPhone, 2 have got Android phone. One wears a Fitbit, one wears a Garmin, one's got an Alexa, one's got a visual impairment, one's got a hearing impairment, one's got a cognitive impairment, etc., etc., etc. And immediately what you see is you need an ecosystem of apps, and what you need is the best app for you. And that's why, so I've said a few times I'm diabetic. When I was first diagnosed, I was 30, I had late onset type 1 diabetic. When I was diagnosed, I needed an app that gave me education and information. I'm now very well educated in this area. What I now need is an app that helps me to measure and trend my blood sugars, so I can connect up and manage my sugars as well as I can. So although my conditions say the same, my needs have moved on. And that's why one app will never meet everybody's needs.
Okay.
Wow. Personalised medicine.
Definitely.
Yeah, fantastic.
I mean, what I liked about your answers is both of your choices are basically communication apps, the social media apps and stuff. And I mean, we've talked a few times about WhatsApp, and we've talked loads about Twitter as a method and tool for communication, particularly for clinicians. You know, one of my big objectives is to try and get as many doctors on Twitter as possible, because actually, you're right, it's such an awesome communication tool. And not just as an individual, you know, wanting to use it and stuff. And like you said, as a news feed, it's probably one of the most up-to-date news feeds going at the moment. But as clinicians using it, there's definitely power there in terms of the communities you can access, in terms of the resources that exist out there. So it's encouraging to hear that, you know, similar people find that the thing that they need to and want to use, kind of thing.
It's interesting with Twitter, because I used to hate it. I probably started using Twitter about 5 years ago, and I think you've got to almost force yourself to use it. And then I remember a couple of years ago when we had the vote about Brexit, and the first thing I did that morning, which made me realise I'd changed the way in which I consumed information, was I picked up my phone and went to Twitter to find out what the vote had been. I then started crying, obviously. but that made me realise, we won't get onto that subject now, that then made me realise that I'd changed the way that I consumed information. And I thought, wow, not turned the television on. I've not looked at a newspaper. I've gone to Twitter.
Wow. Well, it's interesting. Our actual story in terms of creating the podcast potentially started because we heard too much about Brexit on the radio all the time. So that's why we went on.
That's what got us both into podcasts.
Yeah.
So that's it. The radio went on. No more Radio 4 podcasts on the way to and from work.
Yeah. You can delete that word if you want.
We'll bleep it out.
So I guess another question we like to ask everybody that comes in, and it's actually my favourite one. So it's a lot slightly theoretical. So imagine tomorrow morning, Matt Hancock comes to see you, and he says, "Liz, here's £100 million. Yeah, you can do what you want. There's no red tape. There's no bureaucracy to deal with. However, you have to spend it on health tech. How would you spend it?"
So my answer won't be what you're expecting. For me, I think that we have a current gap. I don't necessarily know it needs 100 million, but it might do. And that gap is around workforce development. So I've got to say I'm really supportive of the long-term plan, but one of the gaps in the long-term plan is around the workforce being ready for this digital world. And in our pre-chat prior to this podcast, I think I said, if I did my degree again today that I did 20 years ago, it's almost exactly the same, but yet the world in which we live and work has changed. And we wouldn't ask a doctor to prescribe drugs without them having been trained thoroughly. And what we're asking doctors to do now and clinicians is prescribe digital health. And I think that there's a gap in our infrastructure from university, probably pre-university to be honest, in enabling people and skilling people to be able to work differently in this new world, and that's honestly where I would put the money. I think that we talked about Twitter. You can see some angry clinicians on Twitter, and I think that's fair enough. We're asking them to do something that we haven't provided them with development to do, and it's scary. Patients are turning up with their phone saying, "I'm using this app." It's scary. What do you do with that?
Exactly.
So
I mean, we actually talked that in a recent episode about using wearables, because obviously that's one of the other big techs that links in a lot with the apps and that kind of stuff, because it's backgrounded on that. The way that people are now using wearables to try and monitor their own health data, and then there's that concept of validation from the consumer tech versus the clinical aspect of it. How that plays, do the clinicians trust the consumer aspect in terms of making that supportive diagnosis or not? Loads of aspects of that kind of play into it, I think, and definite challenges. And like you said, there are definitely clinicians out there who just feel it's too much. How can I deal with this on top of all the clinical stuff, the holistic stuff as well, trying to do that as best as we can, and it's a lot to take in. So definitely a mechanism for trying to encourage and build confidence, I think, with clinicians, and to a degree obviously with patients in terms of the stuff that's out there. That'd be really valuable. And it's quite interesting you mentioned it today, because the workforce report by the King's Fund was actually published just this morning, which actually mentions some of that as well.
Oh, okay, good.
Wow, you've read some already, Gandhi.
Actually, I've not read the report, but it's Twitter. So my Twitter feed, NHS workforce was trending this morning, so I had a quick scan of it, and it mentions about the fact that we need to radically overhaul the way that we train our, the number I remember from that is actually, what was it? And by 2028, we need 100,000 more nurses.
Yeah,
that is
not 100, but not just more nurses. We need more nurses and more clinicians who are ready for this new brave world.
Agreed.
And I think that I'm just going to add to that, the second thing is what we don't yet have is a very clear value chain for these products and services to sustain. So I think it was prior to this podcast, you were talking about the fact that you developed an app and it was difficult to sustain. That happens all the time, and that's because the commercial models are not really well established, and that's because apps are really struggling to find their way. App developers, how do you sell your product? How do you embed it into a pathway? And again, going back to the drug analogy, when you as a clinician make the decision to prescribe a drug, there's a value chain, and it's based on a tariff. We need that for digital health at scale, so that me as a clinician, I can be autonomous in my decision making. I'm not being told use that one app. I am able to make the right decision, and there's a value chain, which means that the innovator is rightfully rewarded for their work, so that they can continue to grow.
Yeah, that's a really good point. And you were talking earlier about the need to evidence the impact, and I suppose that feeds into the development of the value chain, because that's what everybody is ultimately interested in, the effect and benefit on the patient.
Absolutely.
So Liz, we've had a great time chatting to you. One of the things that's come through to me really strong and that I've really loved about your approach is focusing on problems. And even in your answer to the £100 million question, you were identifying a problem really, rather than concentrating on a solution, which I really loved. Gandhi, any observations or?
No, I mean, I've been a big fan of ORCHA for a while. We've been talking for near enough 6 months, I think, trying to get this to happen. And throughout that, learning about ORCHA and the journey you guys have had, and seeing the impact and trying to share some of that with my patients. Even now, I'm still picking up more tips as to actually how that will work in terms of the recommendations. I'm hoping I'm going to start using that from tomorrow, if I'm being honest, and things. And I've already tried, whilst we've been talking, think about, okay, so I've got my iPad there. If I do that, I can do that. Anyway. So lots I've learned from this, and I hope obviously our listeners have heard loads as well. I guess if they wanted to find out more, where would you say is the best place for our listeners to go to say, okay, this is where I'm going to find out the most about what I need to do now to try and use apps more effectively for patients?
So I mean, you can go to orcha.co.uk, sign up for our newsletter. We do a monthly newsletter which is targeted to clinicians. And in that newsletter, we do the top 3 apps of that month in a specific condition area. We provide you with information about the top news. We have our head of research who's directing you to pieces of research and studies. We normally have videos in there, which is of clinicians predominantly talking about how they're using apps with patients. It's very easy to access. We use a lot of videos, mainly because I don't like reading droves of information. So go to the site, sign up, join our community. We genuinely want to work with people. We don't see us as driving this agenda forward. We want to work with anybody who's interested, genuinely. So get in touch and let's hear where you're at, and let's see how we can work together.
Well, that feels like a great note on which to end the interview. Liz, it's been fantastic talking to you, and we hope that the viewers and the listeners out there have really got something from the conversation. We hope that they connect with you and ourselves going forwards. So thanks very much from me.
Thank you so much.
And thank you from me. So eGP learners, we hope you enjoyed that episode. We've had a little chat with Liz from ORCHA, and as a result of that, we've negotiated a really interesting deal from her to you guys. So if you were to go to the website eGPlearning.co.uk/ORCHA, ORCHA, then you'll be able to sign up for 3 months free access to the ORCHA app user base as a professional license. So this is the thing that allows you to prescribe apps to your patients and have a trackable and safe way of monitoring that as well. It's a really simple system to use, and we'll be doing a video in the near future that shows you how to use that system as well. After 3 months, the question is what happens then? Well, simply put, if you don't want to use it, that's fine. If you do, however, there is a £25 charge for the annual license, and as a result of paying that, you do actually support me and Andy a little bit, because we get a small affiliate from that particular payment. Doesn't increase the amount that you pay, but like I said, it goes to supporters as well. As I said, 3 months free by going to eGPlearning.co.uk/ORCHA, and we hope that you guys find this a useful offer. We really like it. We've been using it both ourselves, and as I said, we'll be doing a video to show you how to use it more effectively as well, and help our patients as well, and definitely improve digital primary care. Any questions, guys, make sure you feel free to feed back to us. So myself at Dr. Gandalf52, or Andy at DRAW Foster, or both of us at eGP Learning on Twitter, or obviously feel free to contact us on the other mediums that we have. And as always, make sure you subscribe to follow all of our content. And as always, guys, keep tech enhancing your primary care and learning. See you later.